Hi everyone, thanks for listening to all my presentations. Today I will be talking about snake bite and specifically about the treatment of snake bite. I have published the first presentation on snake bite and that was all about prevention and immediate reactions if at all you are bitten by a snake. So today is all about the treatment. Okay, let's go. The first aid, I will not waste your time to go over them all here. You can just check my channel for the presentation on prevention and first reaction when you are bitten by a snake. And you'll get that right here. Please check my channel for that. Okay, the treatment proper. As per the treatment, we'll start with reassurance. Okay, oh, I know what has happened. That must be very difficult for you. We are glad you are here right now. We will try our best. And then you start making the determination as to get anti-snake venom. Immobilize the affected limb by sprinting or bandage. The leg should be well padded and sprint for 24 hours. Promptly transfer to the hospital. Right in the emergency room, we are going to admit. Check for the airway, the breathing, and circulation. Is the patient conscious? If the patient is conscious, that's fine. If not, then we'll go another algorithm entirely. No non-steroidal anti-inflammatory drugs here, no anticoagulant right now, and no surgical exploration of the wound until coagulopathy is ruled out. Still, part of the immediate response is to hook up cardiac monitoring. We are going to get the O2 sat level and give oxygen as needed. We check for the access to intravenous fluid lines. I'm going to set two lines, one for fluid and one to take samples. And we can give ringers lactate. We are going to examine the bite site for fangs and signs of inflammation. We are going to check the snake if it is available, but we will not be encouraging people to be bringing the dead snakes to the emergency room. Why that? Some dead snake can still give us poison. Mortality can envenomate even when dead. That is why previously I've just said that we will not encourage people bringing dead snakes to the emergency room. And then we'll go and take adequate history. Past medical history will be very important because the more the comorbidities, the worse the prognosis. We want to know the medications that this patient is on because certain medications will likely worsen the outcome depending on the type of the snake that has bitten the individual. For example, if it is viper, we might be dealing with hemostasis problem, bleeding, thrombocytopenia. So anyone on anticoagulant or antiplatelets will run into a higher problem. Then the tetanus status should be known and we will help appropriately. Any allergy to any medication that should be determined. Then we are going to mark the bite site. And what are we going to do with that? Every 15 minutes, we'll be checking the bite size for edema, petechiae, bulging, oozing, or gangrene. On physical examination, we are going to palpate the lymph nodes in the affected region. We are also going to palpate for pulses, and we're going to check for compartment syndrome. There should be no surgery until clotting profile of hemostasis is in order. Signs of severe envenomation. Are we dealing with a poisonous snake already? Let me explain further. If you are sure that this is not a poisonous snake, then there's no need to worry ourselves as per whether we'll be dealing with severe envenomation or not. But if this is a poisonous snake and is already identified to be such, then we have all the reasons to worry. Then we will have to check for the swelling and whether the swelling is extending or increasing rapidly. If that is the case, then we are dealing with severe envenomation. Are the lymph nodes enlarged? And if they are enlarged, are they tender? So if we have enlarged and tender lymph nodes, we are dealing with severe inflammatory process, indicating that we have severe envenomation. Early and profuse systemic symptoms will be pointing to severe envenomation. Also, hemorrhagic problems like hemostatic disorder leading to bleeding from thrombocytopenia is a big sign that this is nothing small. And dark brown urine from probable rhabdomyolysis will be a clue to sea snake and severe envenomation. We will head to lab. And what I'm going to do there, we'll first of all take sample for grouping and cross-matching. And we have to do that early enough before the venom will overtake that. Because once there's massive systemic envenomation, we'll not be able to get the true picture of blood group and cross-matching. Urinalysis should be embarked upon, arterial blood gases. Enzyme-linked immunosorbent assay could help us detect the exact species of the snake involved from the venom. Complete blood count should be done, and I put right here reticulocytes, haptoglobin, and bilirubin. Those who are familiar with hematology will know what I'm about to say. And that is hemolysis going on right here? Reticulocytes, haptoglobin, and bilirubin might give us the clue. Blood, urea, nitrogen, and creatinine will give us a clue whether we have acute renal failure right now. And of course, serum amylase will be pointing with creatinine phosphokinase to muscle damage, as could be found in sea snakes. Is there increased PT or APTT and decreased platelets? That might be pointing to viper. Still on laboratory and radiological investigation, we can have EKG and EEG done. Fibrin degradation products should be assayed to know whether we are dealing with hemostatic dysregulation. And of course, when it is raised, that's a clue that we are battling with bleeding disorder right now. Coagulopathy. You can save yourself and the patient by having a quick bedside test to determine whether there's coagulopathy here or not. Remember, I've said earlier, you cannot probe unless you are sure there is no coagulopathy. And even if there's compartment syndrome, you cannot have fasciotomy done unless you have ruled out coagulopathy. And how can you do that by the bedside? You can have a glass test tube and pull 10 ml of venous blood from the patient and leave that for 20 to 30 minutes undisturbed. Then come back and gently tilt the tube. If it is still liquid after 20 to 30 minutes, then you have a big problem called coagulopathy at hand. You can take a guess that this is viper. Certain supportive measures should be taken to help affected individuals depending on presentation or the need. If we are dealing with severe envenomation associated with coma, that is a candidate meant for intensive care unit. If we have bulbar paralysis with respiratory paralysis, then we should have endotracheal intubation or tracheostomy done. If the problem is neurotoxic envenomation, anticholinesterase with glycopyrrolate will be helpful. If this is compartment syndrome, then have fasciotomy. But you must be sure there's no coagulopathy. Secondary bacterial prevention will attract the use of penicillin, but in individual that is sensitive to penicillin, then give erythromycin. The anti-snake venom. The only remedy for or the sole antidote to snake venom is the anti-snake venom. It is very effective. It is an immunoglobulin, not useful in non-snake bites, and there's no fixed dose. The anti-snake venom. The anti-snake venom could be monospecific or polyspecific. The monospecific anti-snake venom is manufactured purposely to neutralize venom from a specific type of snake. For example, contd has a specific anti-snake venom manufactured for that purpose. Polyspecific or polyvalent anti-snake venom has been manufactured to handle venom from different types of snake or from many types of snake. Anti-snake venom will be in powder form and is expected to be reconstituted with normal saline or D5. It must be given at best within the first 4 hours of bite, but for logistic reasons, you can still give it in the first 24 hours. So, if you have the privilege to get to the hospital on time, time is of the essence. While giving anti-snake venom, we should get ourselves ready for the probable anaphylactic reactions. Therefore, we have to get epinephrine or adrenaline if you are in UK, Benadryl, corticosteroid, and salbutamol ready, in case we run into an anaphylactic reaction. And with that, I come to the end of this very presentation. The next presentation will be the full info on anti-snake venom. There I will now go into details when exactly can we administer anti-snake venom, the different types of anti-snake venom, the side effects, the mechanism of action, and of course the expected outcome. Thanks for listening. Remember to share this very presentation. Remember to subscribe to my channel so that all my presentations could reach you immediately they are released once you have subscribed. I appreciate it.